Hello and welcome to Pulmonology Read Aloud. I am Dr. Anshum Aneja Arora and I'm back with another video. And you're right, after a gap, and I apologize for that. But I am back with a video, this time on the guidelines for severe community acquired pneumonia. A shout out to Dr. Moria who suggested this video. Dr. Moria, you had asked for a video on ATS IDSA CAP guidelines. So this is the latest guidelines, which was after the IDSA guidelines. This is the ERS, ESICM, ESCMID, and Latin American ALAT guidelines for management of severe CAP. This was published just last year in intensive care medicine, and it addresses the guidelines for severe CAP particularly. I found this very interesting because a lot of common questions have been answered by these guidelines. So let's have a quick read aloud of these guidelines. Today, the video will be more like a podcast kind of a video. Thanks to Dr. Mayank Saxena for pointing out how he listens to my videos while on the go in the car. So here it is, Mayank, another video that you don't need to see on the screen and you can just listen on the go. So let's get started. So these are the first international guidelines for severe CAP particularly. They are more like another consensus statement which uses the PICO grade questions, which uses voting and arriving at a consensus. 18 European and 4 non-European experts sat down along with 2 methodologists to prepare these guidelines, and they have given 8 very relevant clinical questions for severe CAP diagnosis and treatment. And I really liked how these questions are applicable to all settings, including our settings in India. The background of this guideline is that severe CAP here means all the patients with community acquired pneumonia who require ICU admissions. So it also includes patients who will be having shock, patients who are on oxygen support and require monitoring in the ICU, and patients with the need for mechanical ventilation. It does not, however, separate patients with comorbidities, say patient with liver disease admitted and having a CAP, or patient with diabetes having a CAP. So it talks about a general blanket for severe CAP in very relevant points, and it excludes immunosuppressed patients. It excludes HIV patients, post-transplant patients, patients on chemotherapy. They are not included in these guidelines. Now, as I said, these guidelines have 8 clinical questions. I will be projecting every question on the screen for next few minutes, and I will tell you about the data behind this question. So you need not watch the screen if you want, and you can just listen and understand this guideline. So the first question asked by the experts was that in patients with severe CAP, should we do rapid microbiologic techniques in addition to the current testing, say the blood culture, the sputum culture, the sputum staining that we are doing? Should we also do rapid tests? And this is so relevant because nowadays we have so many rapid diagnostics, the multiplex PCRs available to us. Now, the evidence behind this consensus decision is very low. So, there are not enough head to head trials, which obviously in an ICU setting you'll see on most of these questions. But what they suggest is that if you have the technology, they suggest that you should send a lower respiratory tract sample, whether it's a sputum, it's the ET, it's the BAL, for multiplex PCR testing, which will have an array of viruses and bacterial detection whenever non-standard SCAP antibiotics are prescribed or considered. So what it clearly means is that when you know that you're suspecting or you know that this patient is having a CAP, you are prescribing the routine antibiotics. Should you go for multiplex PCR before that? No, probably. You should do it when you are prescribing antibiotics, which are not the standard ones. You are giving a higher antibiotic, or you're particularly covering Legionella, or you're particularly trying to cover Mycoplasma, or anything, or a virus, say, you want to cover, and you're adding treatment based on that. Then, in that scenario, you can send this testing. The presumption of this recommendation is that all of the patients will at least start their empirical treatment on a beta lactam like cephalosporin group or amoxicillin group in combination with either a fluoroquinolone or a macrolide, because that is what the guidelines say. You have to start a combination treatment with these two when you are suspecting a severe cap. So that is started, and now additional diagnostic testing can be assessed when either you want to escalate the therapy. So you want to cover pathogens that were not covered by this therapy, or you want to de escalate because you are promptly identifying a particular agent. And that, so you are identifying an organism and you want to de escalate to that agent of the combination, or you want to narrow down your empirical therapy. So, what will be the strongest case for multiplex PCR is whenever non standard severe cap antibiotics are prescribed, because obviously it comes with a lot of cost as well. However, they mention that the greatest potential benefit of multiplex PCR will be that you will be able to rapidly adjust antibiotics for the unsuspected antibiotic resistant pathogens. So, probably when you are taking that interval, that 8 to 72 hours of interval where you've started an antibiotic, but you realize that this is probably inappropriate, then you want to escalate it, and then you could do a multiplex PCR. They also say that the weighting of the culture result is something that is overpowered by multiplex PCR because it gives you results much quicker. And so the greatest when you're talking about adverse effects of giving previous antibiotics and then changing to specific ones will be more when you're suspecting these agents or bacteria such as Pseudomonas or Acinetobacter, and then a high quality PCR will definitely warrant a recommendation, because we know that even excessive broad spectrum antibiotic will have more harmful effects. What will be the points against multiplex PCR? One, the cost, and two is inappropriate escalation based on the PCR results. So they do say that if you have a false positive PCR for another organism and you're just increasing the medication based on that, that is one disadvantage that you will have. And they also mention that in most cases of a positive PCR, if your culture comes back negative, then mostly that culture is falsely negative. So here again, you can supersede the decision, because if the PCR is positive but the culture is negative, maybe the culture did not pick it up. And when will this discordance happen? Especially in antibiotic resistant pathogens. And then you will require antibiotics different from the usual cap regime. They mentioned that there is a lot of scope research here as well. We need to study whether it's safe to discontinue the empiric treatment and just go by that Legionella positive or Mycoplasma positive report by PCR. Is it safe to discontinue all antibiotics if your bacterial multiplex PCR is negative, or if it is a viral pathogen that is found out, or when both bacterial and viral come out negative? Then what would you do? Would you go for further sequencing? Would you look at the negative cultures here? So these are some points which still need more research, but the consensus is that if you think that it's something out of the way, exceptional, you can go ahead if you have the availability, but do not use it to guide your empirical treatment at all. The second question that has been asked is the choice of NIV versus HFNO. So they say that if it's an hypoxic patient with severe CAP, can you initiate NIV or HFNO right from the beginning, initially at the outset, rather than supplementing standard oxygen? Because would it affect the intubation rates and reduce the mortality? So here again, the recommendation is very low regarding HFNO, but recommendation is better regarding NIV, right? So they mention that if it's patient with severe CAP and acute hypoxia and he does not need immediate intubation, you can use HFNO instead of oxygen because it has its own benefits. But NIV might be a better option if there's persistent hypoxemia and he doesn't require immediate intubation, but you see that there is a sense of increased work of breathing. So the choice of NIV versus HFNO will not be clear based on the evidence available. But if a patient's primary issue is worsening hypoxemia because of decrease in PaO2 FiO2 ratio or the gradient, like it was happening in COVID pandemic, there was no increased work of breathing, but it's just the hypoxia. HFNO has a strong use, so then you can use that. When would you prefer to use NIV? In patient with severe CAP, when you have hypoventilation or you have an increased work of breathing. And also, if you compare the two, NIV is more easily available, HFNO is now getting more easily available, and they may be slightly more extensive as compared to a simple oxygen. So, that is a precluding factor. But if you look at these modalities, you can deliver a high fraction of inspired oxygen with HFNO with a low level of positive pressure. So, you'll have a more mild positive PEEP effect also, and the dead space ventilation is also kind of obviated. So it will be a good, comfortable option with better oxygenation in comparison to standard oxygen therapy wherever available. And also, see, if they mention that if a patient has a lung injury, and because if his spontaneous ventilation is so tiresome that the breathing efforts are inflicting a self inflicted lung injury, then HFNO may be better. And this has been studied in a study by Frat et al., where they looked at 106 patients with acute respiratory failure versus 110 patients with NIV and 94 patients with standard oxygen. And they said that HFNO had a non significant but a positive trend in reducing the intubation, the ICU, although the ICU mortality did not differ. And if you look at HFNO versus oxygen, then the 90-day mortality was lower in patients in HFNO. So we still need some research here. We need to identify who is most likely benefiting from NIV or HFNO in terms of mortality. This question of preemptive treatment may be used for high risk patients. That also needs study, and we need longer studies over 6 months, 1 year to see readmission rates and the functional status after that. So this is for our question number 2. The question number 3 asks, when using initial empiric therapy for severe CAP, should we use a macrolide or a fluoroquinolone as a part of the combination? Will either of them change the mortality or the adverse clinical outcomes? Again, very low evidence coming from trials, but they suggest that the addition of macrolide and not fluoroquinolone to beta-lactam should be done as empiric antibiotic therapy if you have hospitalized patients with severe CAP. And this comes as a huge boon to people in TB endemic country like ours, where we are wanting to reserve fluoroquinolones for MDR TB regimens. So here again, there are no RCTs that have been identified with head-to-head comparisons of beta-lactam with macrolide or fluoroquinolone. Both are safe drugs. Both are drugs that cause QT prolongation and cardiotoxicity, especially macrolides as simple as azithromycin can set the stage for tossade de pointis. But we also know that fluoroquinolones like levofloxacin, when used systemically, can cause uh, tendon related, muscle or joint or nerve related side effects. So both are at par with both the kind of side effects. You have to explore the duration of macrolide here in the context of de-escalation therapy, that you can de-escalate it in 3 to 5 days. But given that they are more or less on the similar adverse effect profile, they say that macrolide would be a better one. They mentioned that since we had to choose one, we would want to choose macrolide better, although we don't have head-to-head trials. And I think it works very well with TB endemic countries. The fourth question asked was that in patients with severe CAP, can serum procalcitonin be used to reduce duration of antibiotic therapy, so as a de-escalation guide, and improve other outcomes as compared to standard of care where we don't do serial biomarker measurement. So the question is serial biomarkers or serial procalcitonin. The suggestion is again of low quality. However, they suggest that you could use procalcitonin to reduce the duration of antibiotics in severe cap. So here the panel again decided to make a conditional recommendation. They acknowledge that normally if you have a 5-day antibiotic course, that recommendation it precludes either an absolute reduction in antibiotic, you stop the antibiotics, or you would want to go ahead and increase the duration. But that's in mainly in patients without severe cap, that can you stop or you cannot. However, if you look at the potential impact of PCT measurements in patients with severe CAP, the major studies have come from patients with lower respiratory infections, which were not requiring mechanical ventilation. Most data talks about procalcitonin's ability to lower the number of days of antibiotic treatment. It could shorten the antibiotic duration by 2.4 days. But the limitation in the benefit of using this PCT level to guide antibiotic duration are also related to this observation that sometimes when you have a bacterial co-infection with viral cap, in severe CAP patients, you cannot use PCT to reduce the duration because you have to treat that bacterial co-infection. For example, if there's a patient with Staph aureus bacteremic CAP, you require that much amount of duration. So the question arises that will you then do a PCT and determine whether you can stop the treatment? They say you have to follow the guidelines of the duration of treatment that has to be given, and there you will not use PCT to guide de-escalation. When your clinical stability is achieved and duration of antibiotic therapy for 5 to 7 days as needed has already been done, you don't need biomarkers to tell you that you should stop it. So do not do it here. When you can do it in patients with severe CAP is to distinguish bacterial versus viral co-infection because it will increase in bacteria, and when you are deciding duration of individual antibiotics to see the overall load of infection. So PCT levels are something that can be superseded by clinicians. You can use it. However, the role of using it as a serial biomarker will not be there in many conditions given its cost. So that is what comes out. But again, the evidence is very low. It will be able to shorten the treatment, but if the patient's responding, you would anyways want to continue it for the recommended duration. Question number 5 addresses oseltamivir, so viral infections. Should oseltamivir be added to standard therapy in patients with severe CAP and a confirmed influenza? So here, very low, but they suggest that you can use oseltamivir in patients with severe CAP due to influenza, which you have confirmed by PCR. When you don't have PCR to confirm influenza and it is the influenza season, you can use empirical oseltamivir in the influenza season, which is fair enough because most international guidelines recommend oseltamivir for severe campaign influenza. So they just extrapolate this from research in different populations, hospitalized patients, non-hospitalized patients. There are no RCTs in ICU admitted influenza, which is obvious because of the problem of keeping a study control. But there are some studies that were retrieved. So RCTs were not found, but they found that giving oseltamivir as an amivir compared to non-treated patients, the mortality was reduced. So that means you can continue to do that on basis of your suspicion. The next question asks whether addition of steroids to antibiotic therapy should be done in specific severe CAP populations, and will that cause better outcomes in comparison to when it's not used? This is a very relevant question, often asked and often discussed in many conferences. Their recommendation is that if it's severe CAP, you use steroids only if shock is present, and that I think everybody would is following around the globe. It is a conditional recommendation. The quality of evidence is low, but and this recommendation does not apply to whether you're talking about SARS or influenza or MERS causing or COVID causing severe CAP. and it doesn't apply to people who are anyways on steroid therapy. They also mentioned that when you are considering steroid therapy, methylprednisolone at a dose of 0.5 milligram per kg every 12 hourly for 5 days is a reasonable option. What are we looking for? We're looking for mortality benefit, but we're also looking at length of stay, radiographic improvement, duration of mechanical ventilation. So it is a conditional recommendation. There are very large desirable effects, but the quality of evidence and the risk of bias in this recommendation is very high. So here they have clearly mentioned that you have to balance the potential adverse effect and see which type of pathogen you are encountering. And you could also determine those patients where the biomarkers are suggesting that steroid could be used. But the research needs to answer which steroid to use, what are the long-term effects of this steroid use, whether it will affect myopathies, neuropathy, delirium, and what is the difference in reduction of various outcomes like septic shock or mortality or number of patients on mechanical ventilation, and whether bleeding or other side effects are a limiting factor. However, they've noticed that in patients with shock, because of the mortality benefit, it can be included. They also mention in RCT, including 584 patients, a double blind placebo controlled study where methylprednisolone was given for 21 days, 40 milligram for 7 days, 20 milligram for 7 days, and 12 milligram for 7 days. So, total 21 days. They did not see any significant difference in 60-day mortality with the placebo arm. So, with shock, yes. Without shock, be cautious. The second last question of the guideline asks about the appropriate prediction scores for drug resistant pathogens, whether it will lead to more appropriate therapy and improved outcomes. Now, here, this is one recommendation that comes with a good level of evidence, a moderate level of recommendation. The suggestion is you must integrate specific risk factors based on clinical scores, based on local epidemiology, and previous colonization in that patient to guide decision whether you should be treating for a drug resistant pathogen. Obviously, it does not take into account immunocompromised patients and then decide whether this patient should be managed with therapy for drug resistant pathogens. Now, here it's important to mention that this follows the definition of healthcare associated pneumonia because here is the one where we are looking for drug resistant pathogens instead of a community acquired pneumonia. So, nowadays, healthcare associated pneumonia has been asked to be taken off this term. International guidelines have recommended to treat those patients with empirical therapy for drug resistant pathogens whom you suspect this, and not to use this definition for healthcare associated pneumonia that it was like earlier. And they have identified these risk factors for drug resistance, of which there are four main categories: pathogen acquisition related to the exposure, colonization persistence in a patient, antibiotic mediated selective pressure, which can cause resistance, and factors which alter the host physiology. Looking at these, a risk prediction model can be used, and they say that these models are very sensitive with generally low specificity. However, they have a high negative predictive value, and you could use them. One of the models that has been described is the DRIP score. A lot of these can give us guidance whether we should cover for DRP pathogens like MRSA, Pseudomonas acinetobacter, ESBL enterobacteriaceae, and so on. And they found that using these models to guide the decisions will reduce the costs in many, many ways and reduce the need of inappropriate therapy. So, I'm going to show one of these models. This is a study which had compared all of these models, and the highest here in terms of predictive value and sensitivity is the DRIP score, which is followed by the HCAP and the Needleman score. So HCAP score and the DRIP score, this is a comparison. You can look at the screens now for a while. The DRIP score, a cutoff of 4 is taken to decide whether there is a risk of drug resistant pathogens. divided into major and minor criteria. Major criteria is antibiotic in 60 days, residence in a long-term care facility, tube feeding, and prior infection with a drip in the last 1 year. The minor factors are hospitalization in 60 days, chronic pulmonary disease, poor functional status, gastric acid suppression, wound care, and MRSA colonization. Total possible points of 14. This is compared with the HCAP score as per the Blue Journal 2014 paper, which had divided into antimicrobial therapy preceding 90 days, hospitalization of 5 days, high frequency of antibiotic resistance, presence of risk factors, hospitalization 2 days or more in the preceding 90 days, residence in a nursing home infusion therapy, chronic dialysis, home wound care, family member with multi-drug resistant pathogen and immunosuppression. So if you compare these two scores, the drip score actually performs better and scores like. Now, coming to the last question and very, very relevant question, it says, should patients with severe CAP and aspiration risk factors have better outcomes in terms of mortality, length of stay, treatment failure, etc., if you add the risk based therapy regimen instead of standard? What they mean to ask is, should we add anaerobic cover or not in case our patient is suspected of aspiration pneumonia? And very clearly, and this is the only one with very good recommendation and good practice point, that when you're targeting anaerobic bacteria, you do not need to add more specific therapy to target that. So this stems from the fact that most of the standard antibiotic regimens that we're using, beta-lactam, beta-lactamase inhibitors, carbapenems, moxifloxacin, they all contain some anti-anaerobic coverage. So if you want to specifically target anaerobes, that is not more effective. If we talk about antibiotics with anti-anaerobic activity, this includes ampicillin, sulbactam, amoxiclav, moxiflox, carbapenems, and if the patient has a poor dentition, say for example, which could be a source of anaerobes, or if we are suspecting that because he's a diabetic or he's an alcoholic, he may have anaerobic coverage needed. That's not the right indication. So, if even if the pneumonia is of more severity, any severity, you do not add specific antibiotic therapy. They also mention you don't need to do it for aspiration pneumonia also if you're using these antibiotics, because both standard regimens and those specifically targeting anaerobic bacteria regimen are equally effective. However, we know that anaerobic coverage is potentially valuable in those organisms like Peptostreptococcus or bacteroids or Fusobacterium that could be aspirated, causing CAP pathogenesis. So, for example, in elderly patients who are coming from a nursing home or needing ICU care, you could do a protected bowel sampling to show that gram negatives and anaerobes are there. However, when would you specifically add anaerobic coverage? In cases like lung abscess, because there the anaerobes will respond better to clindamycin than to other antibiotics. But if you're suspecting an anaerobe because of an aspiration pneumonia suspicion, that is not the case. There are studies where aspiration pneumonia varying severity has been seen and anti-anaerobic therapy has been compared to antibiotics, and they've shown an equivalence between clindamycin, ampicillin, sulbactam, carbapenem, etc. And good randomized controlled trials also exist. So when do we add it? We add it when there is a specific pathogen that we've identified and we know that here it will work better with say an clindamycin added, or in case of specific scenarios like lung abscess. There is no evidence to support that standard regimen therapy for severe CAP will be less effective than any regimen which specifically targets these anaerobes. And remember, the more antibiotics we add, the more chance of Clostridium difficile infection in an ICU setting. And if you're merely suspecting an aspiration pneumonia, it does not further add complexity in choosing antibiotics. So, The only exception would be, for example, patients with poor dentition or dental treatment or lung abscess, where specific organism and specific therapy is warranted. However, in general, we should not be adding an additional antibiotic to cover a suspected aspiration pneumonia. With that, I conclude today's talk, and it was a very nice question based consensus statement that was released and very valid points, and I'm sure it'll help us in our clinical practice. Thank you, and I'll see you again very soon with another video. Bye bye. Happy reading.